right. So just a quick on the agenda, we're going to be having the committee kind of go through why we're here. So we'll spend a little time doing that. Each committee member will sort of give some insight into that. And then we'll have some presentations this afternoon. As we're going along, because Eric reminded me that a lot of you are from rural areas, urban areas. He mentioned Nevada being 80% people here in Clark County, makes us, I think, like the 5th most urban state in the United States, except that we're also the 6th most rural state in the United States because we're right behind Nebraska in people per square mile. So we're really odd here in Nevada. Everybody's here in Las Vegas and Clark County, and then they're spread out so far. So it's very challenging for our work, especially with the work across the state. But just be thinking about your urban, your rural. There's no rules here. This isn't focusing on just one or just the other, and the same across disciplines. We have people here from universities that are professors, government, community and partnerships. We also have grant-related people, substance use, mental health, nutrition, and that's the beauty of us all being here together. So super excited about that. There's no rules, there's no bring whatever you have to the table, because this is supposed to be a learning, and then we'll kind of go forward from there. So our team's gonna sort of share, and Grace, are you gonna be up first? So Mandy has COVID, so.
Yeah, sorry, Mandy has COVID, so now you have to listen to me. Thank you all for coming. So we're gonna cycle through the meeting planning committee, but I really do wanna emphasize that the meeting planning committee was just that. We just planned this one meeting. You all are the network, surprise. But just to give you a heads up and to kind of get your gears turning as we are going, one of the goals coming out of this meeting will be to develop a steering committee for the Western Region Mental Health and Nutrition Network. So if that's something you're interested in, you might not be now, but after this great presentation, you might be really interested. Please contact us at the end of the meeting. We'll also have a sign up. We're also working to create a hub and spoke model. So the steering committee will be the hub, but we're looking to generate at least 4 to 5 working groups that then can coordinate with the steering committee to make sure that we all are in the know when it comes to the network. I think I have to click on this. I always forget. There we go. Okay, so obviously I'm not Mandy, but Mandy is our excellent Associate Director of Extension at the University of Wyoming. She's on Zoom. Hi, Mandy. Sorry that you have COVID. And then you'll hear a little bit more from Dr. Annie Lindsay on nutrition, physical activity, and mental health. We then will toss it to Dr. Cassandra Nguyen to talk about food access, and then move up to our Northern Region representative, Allison Brennan, for mental health priorities. And her colleague, Carrie Ash, will kind of show us where we're going. So some background. How did we get here? Did a random handful of people from the region just like get on a Zoom call one day and say, hey, let's do this? Not quite that simple, but this was first identified as a need from the Western Executive Directors Association, or WEDA. And they started in, I think, 2018, 2019, so pre-COVID levels of mental health stress. So now we're like up here. And they looked around and they saw a need for mental health programming, and we already have a very extensive network of nutrition programming. But they were finding that there's some mental health programming here, some mental health programming there, but they saw that if we could combine mental health and nutrition, because as this presentation will go on, you'll see how intimately they are related, we should also combine our nutrition and mental health specialists. And of course, this isn't surprising to anyone in this room, but poor mental health is a problem everywhere, but it's especially a problem in the Western region. Coming from Wyoming, I think we have the second highest teen suicide rate after maybe Alaska. And so that is, we're losing a generation to suicide. So that's important that we start to address this. And some gaps that the original steering committee who kind of put this together found was just within research, additional research is needed to describe and understand the relationship between dietary factors and mental health, as well as modifiable risk factors. And that's really where my personal work comes in as a researcher. But then in the Western region, we have areas of diet and nutrition, we have some areas of mental health, but we don't have research or educational efforts focused on the intersection. So that brings us to the goal of this network. It is to improve mental health outcomes across the lifespan through addressing diet quality and healthy food access. So I'll just pause on that for a second. And the objectives of this group and of this meeting is to increase awareness of the relationship between diet and mental health. And it's kind of obvious to everyone in this room, but then when you go back to your states and communities, kind of the well duh for us is the aha for someone else. So conduct research and education to improve mental health outcomes through addressing diet quality and healthy food access. We know that that's a problem in both rural and urban areas, is just simple access to nutritious food. And develop resources that states can add to their portfolio of mental health efforts, either as a standalone piece or an additive to ongoing efforts. And then finally, to increase collaboration regionally and enhance fund development efforts. So something I wanted to highlight that we did even before planning this meeting is we wrangled some grad students and we had them help us with a literature review because we were wondering what already exists in this area. And so we performed a PubMed search with that criteria. I'm not going to read it. I don't know how, like an asterisk, I guess, yeah. But we found 81 papers. And so we had 3 grad students. We made them each read 2 sets of 27 papers. My grad students were not, they were actually pretty excited because they love this. But they then summarized the papers using an a priori Qualtrics survey. And like I said, they each read 2 sets. So we got double data on each paper. But what we found, it wasn't surprising, but it was a little disappointing. There's a high number of papers that met our search criteria, but few specifically focused on the intersection of mental health and nutrition. The papers, when they did, tended to generalize either one or the other. So if it was from a diet researcher, they kind of generalized mental health. If it was from a mental health researcher, they kind of waved their hands and said diet. And so this really indicates that at all levels, work is needed to evaluate food access and availability, diet quality, and specific mental health markers, not just this nebulous mental health. So we also came up with this conceptual model, and it's based on a socio-ecological model, where of course we exist within communities. So we have higher level stakeholders and also pressures, but nutrition and mental health can exist within these communities and interact. And so here we see, we have our dietitians and nutrition specialists, we have psychiatry, mental health specialists. And what we want to get out of this network is really this interdisciplinary collaboration so that we can strengthen mental health and nutrition integration through practical solutions. So some of the things we'll be doing at this meeting is creating a roadmap for existing resources and gaps. Hopefully this will lead to enhanced fund development, develop resources based on gaps, simply raising awareness. And then my favorite, because I'm a researcher, is conducting research and education to improve mental health and nutrition concerns together. So bringing them into the same space and addressing both of them. now I'll hand it off to Dr. Lindsay.
Okay. All right. So that intersection is really critical because we have, I mean, we're represented here, like I said, with substance use, with mental health, and with dietitians and nutrition people and educators. Even Leah's Pantry does a lot of intersection related to nutrition and trauma. And I do a lot related to nutrition, substance use, but that intersection is so raw and we're just not there yet. And it's rightly so, because I know when I talk to these guys from Cassette, which is a substance use center, they say, well, we don't really comfortable talking about nutrition. And dietitians are, we're really comfortable talking about this or that. The problem is if we all stay within our scope and we don't meet that intersection, the intersection is where the constituents are, right? That's where the people are that have these. And so I think I'm so excited, I can't even stop saying it. I know you're tired of hearing about it, but that this is happening because we've got to come to that intersection. And that's what we're here today. So a little bit of background on some of the ways that we know. And I want to, before I talk about how nutrition sort of links to the mental health, especially from a scientific standpoint, I want to put these out there. These are also in that document that you got. We need to make sure when we use the word mental health and mental illness, they're different. Mental illness is collective diagnosable conditions or disorders that involve changes in behavior, such as bipolar, anxiety, depression. Those are mental illnesses. Mental health is effective functioning in daily activities, relationships, and ability to change and cope with adversity. They're very linked together, and this is how they're linked together. But I want to make sure when you use this terminology, if you're talking about mental illness, use the term mental illness. If you're not talking about diagnosable conditions, use the term mental health. I got this actually shared with me from the University of Minnesota Extension. I'm not sure where this individual is from. I probably should have known that before I put this up. But you can Google this. It's in your white paper in there as well. But it shows you how they relate together. Because we know in wellness, people can say, what's the definition of wellness? And if people say, well, it means you're not sick, that's not the definition of wellness. Because people can be not well, but they're not sick, right? That's exactly what's happening here. So what they're saying is on the left side is mental illness, on the right side is no mental illness. But you can flourish with mental illness if you have good mental health, right? And you can flourish if you have good mental health with no mental illness. You're not flourishing if you have mental health stress and a mental illness, is the worst case scenario. But it's also not good if you have no mental illness, but you have mental health stress. So it's a really nice way to look at how that they come together. And I just wanted to throw those out there before we get started, because I want to make sure that we're all on the same page when we use this terminology, because it's not often used correctly. And maybe it's not even right or wrong, but at least we've all come to an agreement on how we're going to talk about it here. Okay, so this is really interesting. I've done these over the years. This is the one I did recently with children, and it used to pop up, obesity and diabetes and all these chronic conditions. And now, as you start doing it and you start putting in the top conditions, now you see depression pop out. You're seeing stress pop out, gut health, mental health, anxiety. This little cloud of what our children are going through is changing constantly. And so I think we just kind of want to start on that page that we're in a different time and place. It was happening prior to COVID, but COVID even advanced it even quicker. So this is really interesting. The prevalence of a healthy diet, they did a study with 1,000 women. And again, this goes back to 2010. This is not like hot off the press information we're talking about. There is information hot off the press, but this is going back, and I want people to understand that. They did a study in 2010 on 1,000 women between 20 and 93, and basically what they found was similar to chronic diseases. We all know that nutrition plays a role in chronic disease. We've all agreed on that. We've known that for years, that it significantly impacts. But now what we know is that the impact of diet quality extends to mental illness. And when compared to a Western diet of processed foods, refined grains, sugars, basically it is associated with lower odds of major depression and anxiety disorders than we find in Western diet. I'm sorry, I said that backwards. But the traditional dietary patterns of healthy eating, fish, whole grains, and such reduces the odds of depression compared to Western, more processed. So let's just talk really quick about the connection between nutrition, physical activity, and mental health. This is a really busy slide, but I just want to give you just a couple of ideas in case you've never really had the opportunity to think about this. But if you look at some of the three major macronutrients and micronutrients, carbohydrates, for example, is the primary source of energy, which is a lot of reasons that people are using substances, that people are depressed, and fatigue has a lot to do with energy. You would be amazed at how many of our mental health is related to diet. So for instance, carbohydrates are the body's main source of energy. So without it, the body can't function properly. Blood sugar becomes unstable, and that really affects people's mental health. Neurotransmitters become disrupted and lead to frustration, anxiety, and cravings. It's also, carbohydrates aid in the production of serotonin. And we know that low serotonin can cause sleep problems, irritability, and depression, and cravings. So people have those cravings, then they eat the high sugar that causes them to get high on the sugar, and then they crash, and then they come back up. And so instead of being stable through a complex, healthy diet, they're going like this. And when they get to the bottom, they're looking for more sugar. And sometimes that can even influence people wanting alcohol more, things like that. So it's quick and kind of dirty, but in terms of carbohydrates and fats, we also know that there's a link between depression, lower fat diet, whole grains, fish, again, have lower odds of depression compared to versus processed meats, et cetera, processed foods. And also fat there's a lot of research out there in our lit reviews showing that fat plays a huge role also in the neurotransmitters as well. So it affects mood disorders. Just a couple examples, just trying to show you. Protein, same thing. That's the foundation of the neurotransmitter. So we know that protein-rich foods increase levels of dopamine and norepinephrine, increase energy, increase concentration and focus. And so those are really important. A higher protein diet. What else? Another study showed low dopamine can trigger individuals to turn to substance uses to feel better. So again, the protein doesn't mean we go out and do a high protein diet. It just means that it plays a role in that. The third one, or the fourth one, vitamins and minerals, super important for basic metabolic function as well as better brain and mood function. There's a huge link between vitamins and minerals. They're part of the gut microbiome. We know that the gut is now known as the second brain. All of those nerve endings and stuff within the gut microbiome directly affect the brain. And so there's a link. I mean, you get butterflies in your stomach, or people like, go with your gut. We've known this for a long time, that there's that link, but now we're studying it more, and there's some research. People are doing fantastic work on the gut microbiome and the importance of vitamins and minerals to diversify that microbiome. And what else? Fibers, super important to the microbiome, as well as improving mood. And we've also seen a lot with in our substance use population with opioid users, right? Opioid numbs the pain. It paralyzes the body so that people don't feel pain. And so it also paralyzes the colon. So a lot of substance use, they need really to get on high fiber, healthier diets when they stop using opioids to help them. It's sort of a natural laxative. And then finally, water helps with cellular metabolism, and also for people that are on medications, a hydrated system will help them absorb their medications better. And the body uses a lot during detox. So when people are coming out of drugs or substance use, it's really important that they're getting rehydrated. So there's a ton of research on this, tons and tons and tons. I've been looking at this research since I started in this area, which this is going to age me now, but it was back in 1997. So I'm really familiar with this, and there's a ton of stuff. So if you're interested in this, I'd be happy to share more about this. But physical activity, I'm not going to get into all this, but these are the physical activity guidelines from Americans right now that came out, the latest version. And these are all things that we absolutely know. They go through, what do we know? It's tons and tons of research that determines whether we're talking moderately no or very strongly no, or we don't know at all. This is what came out as there's strong evidence to support. And difference in habitual and acute, for instance, if somebody has anxiety, acutely, if they get up, you're anxious right now, and you get up and you go down, you walk around the track and come back, the data shows that it will reduce that anxiety. But also long-term feelings of anxiety by people who regularly exercise and are regularly physically active. Improvement on sleep outcomes, which is another whole area. If anybody does a lot of research in sleep, speak up, because that's another whole area we haven't mentioned a lot, but it's really critical to people with mental health issues, with substance use issues, and we need to be talking more about that. Okay, so just how does it look? And one of the reasons we're talking about substance use, and I said it was kind of there before COVID, but it's gotten worse. The use of opioids and stimulants contributed to the epidemic. We all know, we've heard it a million times on TV, that 100,000 people died from opioids last year. I wish it was as, just simple as fixing the opioid problem, but really the opioid problem complicated, because anybody who's in the substance use field will tell you that we've had a meth problem for years and years and years, and all the opioid did was bring that to the surface. Experts are calling methamphetamine the second drug epidemic, but a lot of people that died from those opioids, they weren't overdoses, they were poisonings from people that were using methamphetamine. And they thought they were getting methamphetamine or Xanax, or something for kids looking for mental health, something, they don't want to tell their parents, I got anxiety. They're looking on the internet for Xanax, but it was laced with fentanyl, and so it was called opioid. And a lot of people are not even using overdose anymore. I should put that in quotes, but it's really an opioid poisoning that's happening from other drugs that people are using. So don't think that this is just an opioid problem, because it's absolutely not. And then you can see a lot of politicians will look at this and say, oh, since 2010 till 2020, we did a lot better. This was our substance use in 2010, and now in 2020, we're a lot better. But guess what? That purple one went up. That's a methamphetamine. The orange one, that went up. That's heroin. So while our overall substance use went down, our methamphetamine and our opioid has done nothing but increase. So, and these are based on publicly funded admissions, which for people in extension and people who do nutrition education, that's what you want to look at. There's a lot better numbers, and our SAMHSA folks will tell you there's a lot of really ways you can look at data. I look at these because that's telling us who's in those treatment facilities. And so a lot of education is being done in there. And what is the draw to stimulants? Stimulants, they make you, they help you lose weight. They give you energy. They give you, they increase your metabolism. They make you have to sleep less tired. I mean, what person in America doesn't want all that, right? Especially women, right? We have so much, and we want to have energy and increase and feel good, but then at the same time, we have to look good and maintain weight. And so those are driving some of these use for the stimulants. But then we get up high and then we need to come down. And so the heroin kind of brings, and so this is what we're seeing in the substance use field is the combination of those two. And they're used as a polysubstance. So they won't say I use methamphetamine or heroin or opioid. I use them both together equally. I can't really say which one I'm using more. And that's what's happening. So, and I hate to say this, this is really sad, but one of the biggest populations, this has increased, opioids increased 850% in women in the last 10 years. One of the biggest groups increasing in is reproductive age women. Scary. Just to sort of kind of wrap this up, prevalence of poor diet, this is why nutrition is so important. When people come in, this is a study done on patients admitted to a public hospital detox. They did diet quality, again, this one is 2012. They did a diet quality study on them, and they found 88% of the people admitted to the detox center for substance use required some type of nutritional guidance. One of my staff here said she works in inpatient, that's what she does. She works with those people when they come in and they have nutrition issues. 50% were clinically deficient. So while we might be able to, as nutrition educators, help that, you know, these kind of 88%, these people need more, they're clinically deficient and need a little bit more. And down here, these actually are going to require a registered dietitian or a doctor, because 24% of them were found to have moderate or mild to moderate malnutrition. So this is what our substance use, and unfortunately they're going to treatment centers, and then the treatment centers are like, well, what are we going to do with this? And so look at some of the issues. This is the characterization of people with substance use disorder: malnutrition, low energy, fatigue, impaired metabolism. If you're using methamphetamine, right, it increases your heart rate, it increases your metabolism. You stop using the drug, crash. You have no energy, you're tired, you're fatigued, you're gaining weight rapidly. And for women, that's a problem. It is for a lot of men too, but especially a problem for women. Impaired satiety cues, which I kind of mentioned with the opioids, compromised GI health, poor preferences for poor diet quality foods, weight concerns, disordered eating, and sleep disorders. So this is what people in substance use. If this doesn't tell you why we need to be coming together in this space, I don't know really what will. And one of the reasons that they are coming in like this is because they have poor diet quality before, while they're using the drugs. Their body, when they go into detox, they're throwing up, they're using all their nutrients for detox, vomiting, loose bowels, etc., and then getting into the food insecurity, which you'll hear about next. That's another problem. Why they don't have access, they don't have that as well. And I just want to show you this real quick, just for fun. This is post-acute withdrawal syndromes. This is what substance use people and mental health people talk about when people come out of substance use, is post-acute withdrawal. This is what they're going through. And look at how it's described. If you look this up on the internet, what is this? It's all of these. I don't even have to explain these. These are what nutrition people do and health people do, is address these. And the sad thing is that relapse rates are 40 to 60% within the first 30 days and up to 90% within a year. So it's not working. And SEMSA is joining the conversation, and I'm so happy about it. I love the work that these guys are doing with CASAT, because we have to come together to address this. And then the last thing I want to mention is, this is particularly challenged. I've kind of mentioned it as we go, but particularly challenging for women because of substance use and mental health. A lot of them don't want to take their medications because it causes them to gain weight. A lot of women are going through different things that happen when they're using substances, when they come off, that affect dieting, weight concerns, and eating pathology. So if their metabolism is impaired, Food consumption relies on intuitive satiety cues, so feelings of hunger and fullness. Those are impaired, their metabolism is screwed up, and so that results in overeating, binge eating, dieting, compensatory behaviors, and right into full-blown eating disorders. And they either develop or they resurface. And sadly, if you look at the DSM-5, which defines an eating disorder, for instance, somebody who might be throwing up to lose weight, for example, if they do it once a week, it's not a disorder. And that's because insurance isn't going to cover it, and the DSM-5 says, well, it's not really a disorder. They have to do it twice a week, or whatever. I'm not giving you probably all the right numbers, but disordered eating is really rampant in our mental health, in our substance use population. And there's a lot we can do at the disordered eating level in terms of improving people's diets and outcomes to lessen that before it gets worse. And again, you can see some of these numbers are from, I forgot to put the reference, but this is my study. So it's okay. We looked at how many women who were in recovery for substance use, also co-occurring mental health, how many of them were worried that they would go back to using the drug simply because of how they felt and how much weight that they were gaining. So this is what we know about women with substance use. And we'll talk later about some of the things that we've done to address that, but we've worked really hard here in Nevada to address some of these issues. And we use clinical tools as well as nutrition tools, physical activity tools to show results in the work that we've been doing in all of these areas. I'm not going to go into those, but I just wanted you to see that these are all the areas that are really plaguing, especially women, when it comes to substance use. And I think that's it. Dr. Cassandra is going to speak next.
Thank you.
I didn't want to blow your last name.
That's all right. Yeah. Hi, everybody. I'm Cassandra Nguyen again. Yeah. I went from being Nicolaus to Nguyen, and my life will just never be easy when it comes to my last name. So thank you, Dr. Lindsay, for covering such a wide scope of intersections between nutrition, physical activity, and mental health. I know she covered a lot. So I do want to draw your attention to something that each of you will have in your folder, which is something that was referred to as the white paper. It looks like this. It's behind the agenda. We worked hard to put this together, and it has those sweet figures that both Grace and Annie displayed on their presentation. So if you want to come back to this information later and don't feel like you have to take photos of everything as the slides come up, I wanted to make sure that everybody was aware of this. So I fortunately get to talk about one specific topic that I'm very passionate about, which is food security. And hearing everybody share where they're from or maybe their titles, I could hear that I have some kindred kind of spirits in the audience. So I am going to review some of the basics about food security. It will likely be a refresher for many of you who are already deep in this space, but you may see it through a slightly different angle as we then progress into considering mental health intersections with food security. And I do want to say, this is going to be a real high-level overview. I see it as an appetizer for Dr. Cindy Leong's presentation. She'll be giving our keynote tomorrow, and she will go much deeper and have her specific work that she'll be referencing. Okay, so I wanted to begin with our definition of food security, which is stable access to affordable, appropriate, and sufficient food to support a healthy and active lifestyle. This is, in my perspective, a very kind of idealistic and a very kind of optimistic view of what I would like the world to look like, where everybody has this access. But for many of the households in the US, there are people experiencing food insecurity, which is defined as a circumstance when an individual's access to this affordable and nutritious food is insufficient to support their healthy and active lifestyle. And it can be for a number of reasons and presents in a number of ways. And I do find find that food security is a little easier for many of us to understand, myself included, when we think about tangibly what food insecurity might look like. And so I always lean on these 4 dimensions. These are the core 4 factors that were incredibly informative for the USDA's definition of food security. This was really fundamental work in the late 80s, early 90s, out of Cornell and also out of Seattle, where we really could use the language predominantly among women, middle-aged women who have low incomes, that described what it was like to be food insecure. And so they discussed compromising the quantity of their food, skipping meals, cutting the size of meals, potentially going days without eating. They also talked about the quality, potentially having really redundant, really monotonous diets because that's what they had access to, or potentially even compromising the safety of food because that's what they had access to. And then the other 2 dimensions are a little bit less concrete and like simple to evaluate, because each of these indicators goes into our evaluation of food security, except for the last one. But psychological acceptability is whether or not your emotional response to your food situation is acceptable. So if you're concerned about your finances running out before the end of the month, it can produce anxiety and worry and concerns psychologically around food. And then the final dimension of food security, which ultimately actually wasn't included in the USDA Food Security Survey module because it's such a nebulous concept to try to define for every population in the US, is the social acceptability of the way that you acquire your foods. So for some households, stealing foods or eating foods that have been previously thrown away wouldn't be appropriate and considered socially unacceptable, whereas in other groups or among certain communities that might be considered the norm. There was the movement of like freeganism, if anyone's familiar with this, where there was consumption of food out of dumpsters, not because of financial restraints, but because it was a way to acquire food that would otherwise be wasted. And then of course, for folks that work in the charitable food space, thinking about reliance on food banks and food pantries, for some people, this is completely socially acceptable, that you don't even think about whether or not you're gonna have enough food, that this is a common tactic to acquire food, whereas others would be consider unacceptable. So given the fact that defining what is socially acceptable for food acquisition practices, USDA said, this is too hard. We're not gonna ask people this when we ask them about their food security. But that is all the kind of basics around food security, our definition on our dimensions that we ask about in the US. But I wanted to talk about some additional mental health focused work as it relates to food security. And I always lean on this work from Chilton and Booth that was published in 2007, but relies on data that was collected in the early 2000s. So really still as the seminal work related to food security in the US was being published, where they describe something that's called hunger of the mind. And so when we think about food security, we might think about hunger of the body, the physical effects and the actual dietary components that we're consuming. But there is this other hunger of the mind that appears. So I'm going to read this quote, which is from one of the African-American women that was interviewed for this work. And she says, when you ain't got food, you get depressed and you stressed because you stress yourself trying to figure out how you're going to get it. How are you going to get it? That's the biggest thing. Who I'm going to call, where's I'm going to go, what I'm going to get. So you think about how worry and anxiety about food is one of those initial indicators that we ask about with the food security survey module. But also I think what this quote really reflects is there's also the complexity of our social safety net in the US and the complexity of trying to do something about a food insecure situation. And so navigating these systems in addition to experiencing the actual food insecurity can contribute to this stress, this anxiety, depression, and experiences of trauma. So if you haven't seen this work before, it's really incredible, qualitative work. I do love qualitative work. So they have a model, which I was going to put on here, but is pixelated because it was created in the early 2000s. So I chose this quote instead. But I am going to show you a model that I do frequently rely on because I think it's really valuable. But I oftentimes think about it as it relates to chronic health conditions. And others may have seen this before. So this is from 2010 New England Journal of Medicine, Seligman and Schillinger paper. And it shows, I have a pointer. Oh, great. So it shows here this self-perpetuating cycle of food insecurity as it relates to chronic disease. So you start here with food insecurity, though you can start anywhere on this diagram. And you can think about the constrained dietary options and the coping strategies that households enact during different parts of the month as resources wane and wax. And that these coping strategies then are related to this kind of weight change. Then we have this increased risk of obesity, hypertension, and diabetes. This was published in 2010 and basically has been supported with empirical evidence pretty consistently, with the exception of hypertension, which I won't go into detail, but if anyone wants to talk about hypertension and food security, I'm happy to. But has been supported that there is this relationship to diet-related conditions. That then you think about when somebody has a diet-related condition, then there is the management of that condition. So thinking about medications, adhering to recommendations of doctors related to diet, and thinking about how this leads to increased healthcare expenditures, leading to further competing demands that further restrict what the household is going to have access to as it relates to financial resources. So as you can see, it has this self-perpetuating relationship, whether somebody starts as food insecure or starts as having a chronic disease. And so this is how I oftentimes use this model. I think it's helpful to kind of conceptualize these relationships that we see in the empirical evidence. But one thing that I oftentimes don't spend a lot of time focusing on is these two boxes, which is this idea that stress comes into play here, right? In that we heard from that quote from the Hunger of the Mind paper, is that there is this inherent stress that comes with these experiences. And so this is a very simplistic way in 2010 that Seligman and Schillinger kind of reflected this stress. But since then, we have not only had additional research that has focused on the diet-related diseases, we've also started to see some of the research really looking at where stress comes into play as it relates to these food insecurity and diet-related conditions relationships. And so I'm going to highlight really, I think, just two kind of papers that I thought were really compelling, that I think help set the stage for why food access is related to mental health. So the first one is this analysis of almost 150 respondents from almost 150 countries, where they saw that food insecurity had a consistent relationship with this more negative mental health. They analyzed this data with a regression analyses that adjust for all of these important factors. So you can consider that this is a relationship driven by food security. And I want to show you a figure that I made. There's no figure in this paper, but I made it based on this paper because I thought it would be helpful for this presentation, which is here. So let me orient you. On the y-axis, we have what's called this negative experience index. It's a coefficient. And this is comprised of recent experiences of pain, worry, sadness, stress, and anger. Score can go from a 0 to a 100. And then they have here food security indicated through the food insecurity experiences scale, which is slightly different than the USDA food security survey module. So they use slightly different categories, but you can tell we go from food secure to mild, food insecurity, moderate to severe is what we're looking at. And then we can see here that as we go up in these categories, we see basically a linear relationship with this negative experience index, or this proxy for negative mental health. And so you can see as somebody is experiencing more severe food insecurity, they're more likely to also experience these negative mental health experiences. And this is just really compelling in that it shows this consistency globally. And so this is really compelling evidence even from 2017. But then more recently, people have started to question, okay, if this experience exists, how does it play into that chronic disease or diet-related condition relationship? And one of the current theories is through allostatic load, which is a measure of physiological dysregulation. So we're thinking of like inflammation, cardiovascular disease, metabolic indicators. And that may be our link between food insecurity, poor mental health, and physical health outcomes. Because what they've found in this cohort study of 14,000 adults who are 50 years or older is that greater allostatic load was associated with greater risk of food insecurity. So putting all these puzzle pieces together, thinking about how if an individual is experiencing food insecurity, they're experiencing negative health, mental health repercussions of this, then they have this metabolic, physiologic dysregulation that then is going to predispose them for these higher risk of chronic disease. So hopefully you feel like you've had an appetizer, that your appetite is whetted. I do want to say I'm presenting these other scientists' work, and I'm going to do what I love to do, which is be a bit of a critic. And so to say that there are some limitations of what we know, right? I presented these things that I find really compelling, but we don't know what direction in which these things move, right? So which experience occurs first when we're looking at food insecurity and mental health? And so we really don't have that longitudinal data, which takes years to collect and really quite sophisticated methods as well as lots of money. But what could be really good is doing interventions in this area. If you intervene on food security, do you have improvements in mental health outcomes? If you intervene on mental health, do you have improvements in food security outcomes? That I think could do some practical good, as well as provide this kind of missing information in the literature. So this is my last slide. And I really hope that you agree with me that though we have this really compelling evidence connecting food security to mental health, we will need this longitudinal evidence and promising interventions to make the large scale change that I hope that many of us want. With that, I'm going to conclude and transition to my colleague, Dr. Allison Brennan.
All right, I'm going to try and breeze through this because I realize we are at 2:15. So really what I want to convey here through my portion is what do we need to be paying attention to as far as mental health concerns in the West? And I'm going to end us with some current efforts that exist because I want to end on a note of hope because there's a lot of great stuff going on. And I'm sure over the next couple days, I'm going to learn all about different initiatives I wasn't even aware of. So major concerns that I will touch on here, of course, mental health problems, and we're going to look at depression and general estimates of any mental illness, and then substance use problems. And the reason that I kind of chose to focus on those is because certainly mental health is much more than illness. It's much more than substance use problems, but I think it's really important to think about those particular issues because of their contributing role to suicide, which is really, for me, I think of that as one of the extremely concerning issues in the West. And then I'll go over some barriers to addressing these problems that we should be thinking about as well. And finally, I will end on the hopeful note of the things that I see going on that are really exciting. So in case you didn't know, there is an interactive data platform for the National Survey on Drug Use and Health. It is amazing, and so I cannot take credit for these images. You can literally go to that interactive National Survey on Drug Use and Health and have it create these maps for you, and you can download the image, you can download the Excel file. It's beautiful. So our first map up here, this is any mental illness, so this is past year prevalence from 2018 to 2019. That's the most recent they have on there. And you can see this goes from the darker color means there's a higher prevalence, a high of 26.9% of the population in Utah to a low of 17.4% in Hawaii. So Utah, more than 1 in 4 people adults in the past year had some kind of mental illness. And then if we look down here on the lower map, this is the past year prevalence of a major depressive episode. And so our numbers there are a high in Utah of 9.8%, so about 1 in 10 adults, to a low of 5.8% in Hawaii. Okay, and then if we're looking at substance use problems and substance use disorders, SUDS, sorry, I abbreviated that without explaining that. Alcohol, major problem. So if we're looking at adult rates of binge drinking, about 1 in 5 adults in Montana and Colorado. And then the prevalence of adult binge drinking is above the national median in 8 states. Arizona, Alaska, Colorado, Hawaii, Montana, Oregon, Washington, Wyoming. And this isn't just isolated to adults, right? We look at underage drinking, and again, very high rates of underage drinking, 1 in 4 high school students in Montana and Colorado, which is higher than the national average. Although I should note this bottom data here, the underage drinking, the youth metrics are from the Youth Risk Behavior Survey. And it's really important to note here that Alaska, Oregon, Washington, and Wyoming did not participate in the 2021 YRBS. Okay, so opioids, as Annie talked pretty extensively about opioids, youth opioid misuse, really big problem in Arizona, Nevada, and New Mexico, higher than the national average. Drug overdose deaths. So drug overdose deaths, which are primarily involving opioids, right? About 3/4 of all drug overdose deaths do include an opioid. Increased from May 2022 to May 2023 in 9 of our 13 Western states. And the biggest increases, Washington, Nevada, Oregon, Alaska, and Wyoming. And then lastly, marijuana use by youth. So about 1 in 5 high school students in Montana and New Mexico reported using marijuana at least once in the last month. And that, again, higher than the national average. And so I have an asterisk there to indicate, yes, recreational usage is legalized for adults 21 plus in those states. However, these are youth under the age of 18 primarily. And I could talk a lot about the different impact on an adolescent brain versus an adult brain. So this is a concern. And then if we look at diagnoses, so these are the estimates of prevalence of any substance use disorder among adults age 18 or older. And here the range goes from 11.8% in Colorado, and then a low of 6.6% in Utah. And another important point here is that often substance use disorders are comorbid or co-occurring with another type of disorder. And so this is them parceled out. And then if we look at specifically alcohol use disorder, because it was pretty clear on those last slides, right, that alcohol is a big issue. Alcohol use disorder in the past year among adults, that ranges from 8.8% in Colorado to a low of 4.5% in Utah. All right, I realize that this is pretty intense here, so that's why I left the hopeful slides at the end. So suicide, this is why I really focused a lot on substance use and especially alcohol, as well as depression as a mental illness, because those are major risk factors for suicide. And this is a huge problem in the West. If we look at the suicide mortality rates, the most recent ones from 2021, Wyoming, number 1, Montana, number 2, Alaska, number 3, New Mexico, 4, Colorado, 6, and Nevada, 8. And so this is like, wow, the West, right? And then if we look at among youth, and again, remember, we don't have some states represented here, but if we look among youth, suicidal ideation and behavior, in the YRBS, they asked, in the past 12 months, have you seriously considered suicide? The national average is 22.2%. More than 1 in 5 youth said they had seriously considered suicide in the past year. And that's the national average. And then we look and we see how our states compare. Thankfully, New Mexico and Hawaii are significantly lower than the national average. And then in terms of attempting suicide, 1 in 10 youth in the United States. And again, thankfully, Hawaii, we do see there that it's lower than the national average, but just astounding. And I see, I look at this data all the time, and it just never loses its impactfulness. It's a lot. Contributing factors, I'm going to skip over those because of time, but there are a number of contributing factors, some of which are unique to the West, some of which exist everywhere. And then some additional concerns as related to mental health. Of course, the issue of availability of services. Do services even exist in a given community? And then accessibility. If services exist, can you even utilize them? Things like, how much is it going to cost? Do I have health insurance? Does my health insurance cover this provider? Distance to services. So when Annie was talking about how the population of Nevada is so spread out, and then there are these major urban centers, somebody maybe would have to travel an unbelievable distance to get the services that they need. And then some other considerations there. And then acceptability, which is really about if services exist and they can access them, is that going to be socially or culturally acceptable? So is that going to be a good experience for them? Is it going to be compatible with their own values and preferences? And so, and then other factors that can impact whether they're willing to utilize those services. For example, comfort with telehealth. So maybe there's a free telehealth program, but they're not comfortable with that as a mode of talking to someone. Okay, so things that are happening that I think are amazing in the West. I'm going to start with 3 ways that land-grant institutions are prioritizing mental health, and I know this is really extension-centric, and part of the reason for that is that this effort did originate with an extension, and so certainly I'm not trying to exclude anyone, and as the week progresses, I hope that we are going to hear from people outside of land-grant institutions about what they're doing, and I think there's incredible potential for public-private collaborations to address this, and so that's just my little caveat there. So, number 1, hiring dedicated extension specialists. Hey, that's me. As far as I know, I am the first dedicated mental health specialist in the West, and I started in 2019. Woo, yay, Montana! Very forward thinking. I'm looking at Carrie. And in 2021, we had Chad Resnicek, who signed on with Colorado State University's Agribility Project. Do we have Colorado State University? Yay! All right, good. And then in 2023, CSU hired 3 regional specialists in behavioral health. And now I would be remiss if I did not mention that New Mexico State University is currently hiring for an extension state specialist in behavioral health. And I swear I was not planted up here to say this, but if you have questions, you can talk to Kareem Martinez, who is the chair of that search committee. I feel personally motivated for somebody to land in that spot, because then I'll have a really good colleague to work with. Okay, implementing evidence-based programs. And this is not an exhaustive list, but just a sampling of ones that exist in the West. So mental health first aid and youth mental health first aid, these are from the National Council for Mental Well-Being, formerly the National Council for Behavioral Health. And these are full-day trainings that teach signs and symptoms of different types of mental health problems, and it's really focused on the response plan. So how do you approach someone who's having these problems? How do you make sure that you get them to the services that they need and that they feel supported in doing that? Question, Persuade, Refer, or QPR, which is a brief suicide prevention training. And then Youth Aware of Mental Health, otherwise referred to as YAM. And that's a program for high school youth where they learn, it reduces stigma around mental health, and they learn about different coping strategies to positively deal with life's problems, and also how to get help for a friend or for themselves by reaching out to trusted adults. And so they do a lot of role playing in that program to get them experienced with and comfortable with those kinds of conversations. Collaborative projects, so I have highlighted the Rural Opioid Technical Assistance Regional Centers there. I think there's just been some amazing work being done through ROTA, and prior to the regional ROTA, a lot of states had, a state level program. Montana State University had one, and just amazing stuff going on there. And we're gonna hear from someone, aren't we? Am I making that up? From one of our ROTA R? Yeah, okay, we are. And then RASSUP, the Western Regional Agricultural Stress Assistance Program. We love our acronyms. So this is a huge collaboration supported with USDA Farm and Ranch Stress Assistance Network funds, and the lead institution is Washington State University, Skagit County Extension. But there are a ton of partnering institutions, and so if you want to learn more about this, farmstress.us. I've also got some materials on the table over here, but this is a massive undertaking. A lot of these institutions have sub-awards, and they're doing their own projects. And then we've done a bunch of data collection. I've got copies of our aggregate report there if you want to take a look at that. And then here we are, the Western Region Mental Health and Nutrition Network. I am also very excited to be here. And this is a collaboration. This is, hopefully going to bring together all kinds of disciplines and institutions, and we'll see where we go. So just quickly, I wanted to touch on a few example programs of combining nutrition and mental health. So of course, in the West here, we've got Healthy Steps to Freedom. That's our very own Annie Lindsay. And I didn't realize it the first time I met her, but she is a pioneer. She is leading this effort. And then in the South, the Slow Down program. And this is a program that combines mindfulness with nutrition topics. So it includes content on sugars and fats and how to eat healthy on a budget and how to deal with picky eaters. It's a program designed for mothers of young children. And I have 2 peer-reviewed research articles on that program. So if you're interested in those, let me know. I can send them to you. And then the North Central region, Healthy Body, Healthy Brain. This is out of Kansas State University. And this is a single session one, but it's adaptable for different audiences, and it's really a comprehensive program that includes physical activity guidelines and different nutritional guidelines. And I just wanted to mention very specifically the Mind Eating Plan, the Mediterranean Dash Intervention, which does not mean a lot to me, but I'm sure that means a lot to some of you. And so it's a hybrid of the Mediterranean and DASH is dietary approaches to stop hypertension. But they also talk about sleep and the importance of remaining cognitively active and so forth. And should mention both the participant handout and the facilitator guide for this are available online from Kansas State University. All right, so I want to leave us with this quote of inspiration from my favorite transcendentalist. Do not go where the path may lead. Go instead where there is no path and leave a trail. And that's what we're doing this week.
Thanks, Allison and team. I stand before you in between you and break in a lovely garden outside, so I'm going to keep it brief for you. My name is Carrie Ash. I serve as the Associate Director of Extension at Montana State University. Thank you to my conference planning colleagues for laying the groundwork today. I'm just going to speak briefly about where we are going to move forward. And I'm giggling because I didn't know this slide was going to be up, Allison, but I would encourage us to leave a trail while bringing a friend along with us. Because I think, starting with what Annie said, this isn't necessarily a time to stay in our lane. So let's pave this trail with a friend by our side, because staying in our lane might get us to the same spot that we're already in. We've got great nutrition interventions. We've got great mental health interventions. This week is a time to think about the two together and the intersection between them. Did you have a clicker? Thank you. Okay. So just going forward, in the next couple of days, you saw our overall goal is to improve the mental health outcomes across the lifespan through addressing diet quality and healthy food access. And you also saw our objectives. I would draw your attention, because these are very broad and we are going to work towards these things, but I would draw your attention to the 2-page white paper that the other speakers referenced. There is some short-term goals on that white paper, and those are the things we're really going to focus in on in our next couple days together. We're going to be working to create a roadmap outlining the existing resources and gaps, and we're going to do that in facilitated working sessions in circles in the room next door, because what is a good extension event if there's not some facilitated conversations, right? And then we're going to define some priorities according to this group, the expertise in this room. We're going to look at priorities for research and extension efforts in food systems, mental health, and nutrition integration. So using the expertise in this room, we're going to consider what we have and where the gaps are. We're also going to connect as a network. You heard Grace kind of give our call for the start of the network. Connect with our colleagues to advance research and education. We're going to form working groups. Oh, I'm sorry, I forgot about Zoom. Sorry, folks. And so those are 3 things that we're going to do this week as we work towards the overall goals. So hang with us. We're going to learn more from a variety of folks, and we're also going to engage with one another once a day next door in that room. And now I'm going to pass you to Annie for a tour. Annie, are you touring us? Let's all enjoy the outdoors for a few minutes. I think I caught us up a little bit.
Thank you. All right. So I think we had somebody that was going to be available to answer questions. I don't know. We're running behind, so he may or she may or may not be here. But we're going to get up and take about 15 minutes. I know